We report the preliminary experience with preoperative use of three-dimensional virtual model to guide the surgical approach to the complex Hilar renal mass and to the vascular anatomy of the kidney during robot-assisted partial nephrectomy. We present one such procedure, performed for a 34-year-old female with incidentally diagnosed right renal mass. Preoperative creatinine was 0.7 mg per deciliter. CT scan revealed right renal hilar mass with 5.5 by 4 by 3.5 cm, renal score 10 AH. Three-dimensional virtual reconstruction of an anatomical model including the mass, the renal parenchyma, the pelvicalisal system, and the vascular anatomy, showing both extra and intrarenal, arterial and venous branches, was created by Urologic. This is the standard port placement for right partial nephrectomy. The initial step includes hilar dissection and taking control of renal artery and vein. After this, the tumor was approached. A prominent vein draining from tumor into the renal vein, as identified preoperatively on the 3D reconstruction, was isolated, clipped and divided. Then the hilar dissection was continued, posterior to the tumor, meticulously skeletonizing the renal vein, for clear exposure of the tumor, and to minimize the traction on the vein. The Gerata's fascia was carefully opened, over the anterior surface of the kidney. Dissection was performed in a manner to expose the tumor, while deliberately preserving the perinephric fat over the mass. Several small venous tributaries draining the tumor were clipped and sharply divided. This step was crucial to ensure complete mobilization of the tumor from the hilar structures. The robotic ultrasound probe was introduced from the assistant port and was then moved side to side and front to back to identify the limits of tumor. ICG dye was injected intravenously and Firefly mode was activated to assess perfusion and define tumor boundaries. Renal tumors generally do not take up ICG, appearing distinctly darker than the surrounding well-perfused renal parenchyma. The capsule was then scored circumferentially around the lesion, using monopolar scissors, guided by the ICG demarcation. The cranial margin of the tumor was reaching up to the lower border of renal vein. Following the scoring, intraoperative ultrasound was employed once again to confirm the boundaries, ensuring a complete and oncologically safe resection with negative margins. In routine cases, only the renal artery is clamped. However, given the hilar location of this tumor and its proximity to major vascular structures, both the renal artery and vein were clamped in this case. The tumor resection was then initiated using cold scissors along the pre-scored margin. One vein draining the tumor directly into the renal vein was identified intraoperatively, exactly as anticipated from the preoperative 3D reconstructed virtual model. This vein was carefully dissected, securely clipped, and then divided. Here, you can see its precise location in the 3D model. Resection then continued, guided by the anatomical roadmap. The feeding artery, clearly visualized on the 3D model, was accurately identified, clipped, and divided. This greatly facilitated targeted dissection and vascular control. The dissection then further progressed, with the cold scissors, following the curve of the tumor. Throughout the resection, any additional vessels encountered in the tumor bed were promptly clipped to ensure hemostasis. Effective suctioning by the assistant played a critical role in maintaining a clear operative field, allowing optimal visualization of the tumor margins and facilitating counter-traction. The 3D reconstructed virtual model had predicted that the tumor was in close proximity to the pelvicalisal system, with a separation of less than 1 mm. This critical anatomical detail enabled heightened intraoperative awareness, helping to anticipate and manage potential collecting system entry. The pelvicalisal system was inadvertently opened as anticipated, and a 6 French ureteric catheter was placed beforehand for normal saline installation. It can be closed separately using a 4-0 Vicryl suture. Alternatively, in other cases, it can be closed concurrently during the inner renarrhaphy, in a continuous manner using the PDS suture. Inner renarrhaphy was then performed, using a running 3-0 PDS suture, with hemo-lock clips applied at both ends, to maintain tension and achieve compression across the tumor bed. The clips were then slightly tightened, to enhance compression and hemostasis. Following inner renarrhaphy, both vascular clamps were removed, with a warm ischemia time of 27 minutes. The resection bed was again inspected for bleeding, and once hemostasis was confirmed, the renarrhaphy sutures were further tightened, and an additional hemo-lock clip was placed, to prevent slippage and maintain compression. Once again, Firefly mode was activated, to assess renal perfusion following clamp release, and to inspect the resection bed, for any non-perfused areas of residual tumor. To reinforce hemostasis, flow seal was applied over the resection defect and allowed to act. This was followed by placement of a Surgisno hemostatic sheet to provide an added layer of protection. Finally, an additional layer of 3 OPDS sutures was used to reapproximate and close the Gerata's fascia over the resection bed. Coming to the results, the total operative time was 170 minutes, with a console time of 130 minutes, with warm ischemia time of 27 minutes. The estimated blood loss was 200 milliliters. She was discharged on the third post-operative day, following an uneventful recovery. Creatinine levels at discharge were 0.8 mg per deciliter, remaining stable at 0.6 during the follow-up. Final histopathology determined clear cell renal cell carcinoma, Fuhrman grade 2. Preoperative 3D virtual reconstruction provides a comprehensive anatomical roadmap that enhances surgical planning and execution during partial nephrectomy, particularly in anatomically complex cases.